Episode of You've Got the Power. I'm your host, Dr. Jason Deitch, of course, with founder of Regenix and medical director at the Centeno-Schultz Clinic in Colorado, Dr. Chris Centeno. Dr. Centeno, good afternoon.
Good afternoon, Jason.
Let's get to questions. If you are a regular viewer of this show, you know this is the opportunity to ask Dr. Chris Centeno, really the founder of regenerative orthopedics as an industry, as a profession. Now is your time that you can ask any question you would like to about your health, about stem cells, about what's going on in healthcare. You can ask. We'll ask the questions together. We'll learn together. Today, we'll kick off today's conversation, of course, with everybody I know is reading your blogs. It's hard enough for us to stay up on reading them, let alone admire how long it takes for you to create them. I know that recently you've been sharing some specific cases of people that have had issues and had them resolved. Let's get into thumb arthritis and what people should be doing about it.
Yeah, Jason, the most common form of thumb arthritis is what's called CMC arthritis. So that's kind of at the base of the thumb here between the thumb and the wrist. And it's super common with obviously all the texting we do, all the typing we do, all the computer interactions that we do. It tends to be more common in women than men, but men get it as well. And it's pretty disabling, as you might imagine. If you can't use your thumb for much, it's hard to open doors, it's hard to shake hands, it's hard to do the typing type stuff. I blogged this weekend on a patient who I had treated maybe 3 years ago, somewhere in there, who was an artist. And he came to me in this really nasty old thumb splint. He really couldn't even be out of that thumb splint. Obviously, for an artist, that was his dominant hand. So he had been working in clay, couldn't do that anymore, had tried to take up some painting, he could do that. But again, only limited bouts of it. And it was really affecting his ability to enjoy life and do what he liked to do, and actually how he made his money as well. So, I treated him using an orthobiologic procedure to treat CMC arthritis that I developed. And the reason why I developed it was because the only real other option for these patients is to take out one of the carpal bones. You got a bunch of little wrist bones in here. Is to take out one of those carpal bones and then take a tendon from in here and curl that tendon off and stuff it in that area and then close it up. The problem with that surgery is about 1 in 7 patients have a pretty big complication from that surgery. So it's a very invasive procedure. Now, this gentleman was treated a total of 2 times, about, let's say, 3 months apart. Here we are 3 years later. He's gone back to full activity and just sent me an email saying, "Hey, doc, I want to let you know I took up the guitar again. I haven't played the guitar in a decade because of my hand." He had sent me a YouTube video of him playing the guitar. So it's an interesting thing because I see these patients all day, patients who have thumb CMC arthritis, who have been told they need surgery. That's the only option. And we treat these people with a high success rate procedure, usually 80% or more, get to avoid surgery and don't need to have that big procedure. So, this is a good topic because it's such a critical thing. It fits with our technological world. We're seeing more and more of it. And yet, probably 80% of those people who are told they need surgery really don't need that.
Let's get into what are some of the early signs. How would somebody know if this is an issue? Is it affecting younger people with all the texting and joysticks and game playing and so on? How does somebody know? As we always say, smaller problems require smaller solutions. It's common that people just wait until it's a complete disaster and they are disabled practically, or it stops them from doing what they want to do and or in some cases is their livelihood to do. How does somebody know early on if they should be getting something checked out versus not overreacting?
Yeah, obviously, if you've got a little problem with just some transient pain in your thumb and it goes away and it doesn't return, that's no big deal, no harm, no foul. But these are people who really have increasing pain in this area. Any activity in the thumb will make that pain worse. Many times they have a hard time sleeping because it tends to swell at night. And they're starting to change what it is they do. Now, obviously, the sooner we get to that, the better. So if you've got pain in this area that's slowly getting worse, you're starting to find yourself not doing this or not doing that, avoiding shaking people's hands, those sorts of things, then it's time to get in and get that taken care of. Obviously, small problems, small solutions, big problems, big solutions.
Are there things that people can be doing for self-care? Are there postures that they should be doing, stretches they can or should be doing before and after using their hands in particular ways? Should they be bracing and other types of early interventions? What is somebody who's either early suffering from this or trying to see if there's a conservative approach before moving on to that level of care? What are some of the things that they should know if they're suffering from this?
Yeah, so a pretty simple thing to do, obviously, would be going to Walgreens or just on Amazon buying a thumb splint called a thumb spica splint, and just immobilizing the area for a couple days and seeing if it goes away. If it does, then obviously fantastic. We also see a big crossover between pain in this area and carpal tunnel syndrome. So the median nerve in here getting entrapped, or the C6 nerve in the neck, which goes here, having issues. So sitting on a computer all day, postural issues, allowing your head to come forward, all of that will make this worse. So you might, again, want to try more conservative care, things like occupational therapy, chiropractic care, etc., to see if that gets rid of this issue. And if it's still not going away, that's when you either going to look at the big surgery, which we've talked about and has all sorts of problems, or this type of treatment, which is much, much less invasive.
This is why we say you've got the power, because you watching have the power to make the right decisions on how you take care of yourself, whether you neglect small issues and hope they'll go away and basically let them get progressively worse over time until you can't take it anymore, or whether you learn about how your body works if you're experiencing pain. Again, Dr. Centeno just explained, it could be local to the joint, it could be local to the wrist, it could be non-local from the neck going to the wrist, lots of different causes. And I just want to explore the consequences of letting this go for too long. Surgery becomes sort of the last ditch effort if you've tried everything. I know, people, I've had plenty of patients who, had their carpal tunnels, surgically incisions, breaks the basically very strong integrity that requires the nerves, the bones to hold their mobility. What are the consequences of letting this go too long, both in terms of having the surgery, the effectiveness of the surgery short term, and most importantly, long term? People have had surgeries, they go, oh, my pain's gone away. I see them a year or two later, they go, it's worse than ever. So everything is within the context of when you're asking and when you're measuring. If you're a long-term thinker and not just it's good today, I had the surgery just a few weeks ago, and you're not looking into the future, you're not looking at a big enough picture. Doc, what do you know and what do people need to be aware of on that?
Yeah, so let's take that surgery that you talked about, which is carpal tunnel release, because that's a good place to start. There's a ligament that goes across here called the transverse carpal ligament. Now, it's not an extra spare part. It's there to stabilize the wrist. It almost would be like if you took a piece of duct tape and you wrapped it around your wrist. That's what those ligaments do. They keep all those little bones in here, and there's a bunch of little bones right here, together and stable. So if we cut that ligament, I don't care if we cut it minimally invasively, if we cut it surgically, it doesn't make a difference. We are reducing the stability of all those carpals. In the same way, if for CMC surgery, if we take out this carpal bone right here and we stuff a tendon in there, again, we're changing the entire biomechanics of the wrist. When we do that, there's a bunch of bones in there that are perfectly shaped like a puzzle to go against each other and to move against each other. And there are ligaments that hold that whole system together. So if I go in and disrupt those ligaments and yank out one of these bones, that's a biomechanical disaster. So that's the problem with those surgeries, is that we're dramatically changing the original equipment. So to the extent that you can keep that original equipment, that's always the best option.
There you go. So hopefully that's taught you something, both if you are suffering from a wrist CMC issue in your thumb, and these principles apply to all joints of the body. So you can apply the concept to your injury, your concern. And speaking of, we've got some questions coming in, so let's head on over to some Q&A. Isaiah is asking, are there better stretches for intersection syndrome? And he says, thankful for the opportunity to try Regenix. Intersection syndrome. Thank you for your question, Isaiah. We'll see what that means exactly, or where your context is for intersection syndrome. Not familiar with that term myself.
Yeah, it's a wrist problem, but one of the concerns there is, again, we don't really have a diagnosis. So intersection syndrome is just kind of wrist pain in this area. Now, there's lots and lots of reasons why that could happen. For instance, if we did an ultrasound and we saw swelling in certain tendons, those specific tendons would need to be treated, and we would need to know that those muscles start up here. And then we would need to know that those muscles connect to nerves in your neck. So there could be a problem at any of those three levels. Same thing with the little bones in here. If these ligaments got injured at some point in your life and those bones are moving around too much, that can cause pain in here. So I don't really consider intersection syndrome a diagnosis as much as a descriptor. What I mean by that is that we have these things that really just describe what the symptoms are, but they don't in any way, shape, or form get to the cause of why those symptoms are there. So I need to know why that wrist hurts in that area between the wrist and the forearm, not just that it hurts in the area between the wrist and the forearm. And there are literally a dozen things that can cause pain in that area.
That is such a valuable and important thing to be aware of as viewers, as listeners, is understanding, medical terminology is filled with exactly these types of nomenclature and names for what you describe. You, the patient, the joke sort of is somebody walks into their traditional doctor's office and they say, it's warm, it's red, it feels inflamed, in my joints, especially my fingers. The doctor says you have arthritis, which is simply a different language for saying you have inflamed joints. When you know the translation, you go, well, you didn't really tell me very much. You just translated what I told you. And that's part of sort of the medical terminology, that I'll say prevents people from having the power to understand what they really have going on. That the key focus is asking exactly what you said, Dr. Centeno, understanding what's causing this to happen. Not what's the description of the end result. Inflammation is throughout our bodies, and there's all kinds of arthritis. It doesn't give you necessarily the here's what to do about it. In some cases, people go, oh, okay, now at least I know what I've got. And then they look for some sort of medicine to relieve the symptoms of the diagnosis. Totally different perspective than addressing the cause. Yes.
And I'll tell you what I'll do. I think that's a great topic for a blog on the Regenix site. So I will try this afternoon to go ahead and blog on intersection syndrome and all those concepts we just talked about, so that you've got a much more in-depth look at that than just someone answering a question online. But again, it's all about the why and not necessarily the what. So when we have diagnoses like that, they're just, as Jason said, taking what you told the doctor and going ahead and putting that into a diagnosis. So as an example, SI joint syndrome is another one. So that's taking an anatomical part, the SI joint, and saying, well, you got pain in your SI joint. We know that. The problem is why? Why do you have pain in your SI joint? Is it unstable? Are the nerves going to that area bad? Is there biomechanical overload happening? So you got to get to the why, because unless you get to the why, you're never going to get to a treatment. And that's just, I don't care if that's medicine or fixing your car. Your local mechanic knows he needs to get to the why, or else he's not going to be able to fix your car. But we doctors somehow don't seem to get that.
It's fascinating. It's just the way the system is, and that's why we do this program. Is the smarter you are about how the system works, the better you are, more powerful you are to navigate the system, to understand. When a doctor says, here's your diagnosis, that you don't just go, oh, okay, I've got XYZ. You go, oh, well, thank you for telling me what I told you. Now, what do you think is causing the problem, and what can I do to address the cause? Understanding very clearly that medication does not correct causes in most cases, especially when it comes to pain syndrome specifically. Medications and surgeries are specifically focused on reducing the symptom, reducing the effect, not the cause, with all kinds of dangerous side effects that go along over time the longer you live on those medications. So that's we look forward to that blog post. Isaiah, we thank you for your question. Keep your questions coming. And that's really what this program and Dr. Centeno's blogs are all about, is to help all of you get smarter. Getting smarter means getting more powerful. We are in uncharted territory in our healthcare system. The stakes have never been higher. The smarter you are, the more protected you will be. Let's move on to Doug, a regular viewer. Hey, Doug, thanks for watching as always. He says, or asks, if someone already had their first bone marrow aspiration, how much time is needed before a second stem cell bone marrow aspiration and or PRP procedure could be done? What's the time delay?
Yeah, Doug, so we generally give it about 3 months between bone marrow aspirations. Now, if you wanted to do a PRP injection, that time limit doesn't apply because that's taking your blood. So about 3 months to repeat a bone marrow procedure, or really no time limit specifically if you're just going to go from a bone marrow procedure and get a PRP shot.
Right on. And there you go, Doug. Thank you for your question. And if you have something specific for you, contact the Centeno-Schultz practice and we can get specific with your particular case and condition. Moving on to Ryan. Hey, Ryan. He's asking the question, is PRP effective for tibial bone marrow edema?
Yeah, so that's a good question, because it's important to understand that there's a big relationship we know now between what's happening in the bone and what's happening in the cartilage inside a joint. And bone marrow edema, or a bone marrow lesion, it's called really both of those names, means that there's swelling in the bone marrow or increased fluid in the bone marrow in a certain spot, usually the spot where the bone is getting beat up the most biomechanically. And what's interesting about those edema areas or those lesion areas is that those are more likely to be associated with pain than even cartilage loss or meniscus tears. So we've got a medical system that's hyper-focused on cartilage loss and on meniscus tears, but the research showing that that's related to pain is not great, meaning that if we take 100 people who have cartilage loss, a lot won't have any pain. If we take 100 people who have meniscus tears that are in their 40s, a lot won't have any pain. But if we take 100 people who have bone marrow lesions or bone marrow edema on their MRI, a substantial number of those will have pain. So it's an indicator of a joint that hurts. And as a result, we've seen people try to treat those. So there's a couple of different ways to treat them. One of the ways that's being thrown around out there that I really don't like is injecting bone cement into the area, because that's an unnatural substance. But on the other hand, you can inject orthobiologics like PRP or bone marrow concentrate. And we've had better success with bone marrow concentrate, meaning a bone marrow stem cell procedure, than PRP. But there's some research being published on just using straight PRP into those bone lesions. And then again, how do you do that? You have to inject directly. We will use a very small microtrocar under X-ray guidance to make sure we're getting good coverage of that spot. So that's bone marrow lesion and bone marrow edema, but those are very important topics in osteoarthritis research right now.
That is a great question, Ryan. And, it's so important to learn, again, how your body works. When you look at the structures and depend on the structures, it's kind of like saying, oh, the car has a dent in it, and that's going to affect its performance. Yeah, maybe not so much, but when there's edema, that's a physiological process. That is the body's way of adapting to an injury in process. And so that is a much greater indicator that healing needs to happen, as opposed to, a dent happened. There's people that can drive their cars with lots of dents, and it never really affects their performance very much. Again, we're not talking about, hyper cars doing, races necessarily. We're talking about transportation. And that's the difference, is understanding what the physiology is, as in that edema, that swelling, and what's causing that, versus what, again, most of mainstream medicine has focused on, which is look at the imaging, look at the MRI, look at the X-ray. There's the damage, when, again, consistently the research says that pain doesn't often correlate with where the damage is. It's simple to show people see that. Yes, I think I sort of maybe kind of, if you see that, I guess I do too, is the way most people answer that when they look at X-rays or MRIs. But it seems to be a linear approach, but not really an accurate approach. So super question. Thank you for asking. Let's keep going. We've got one of the questions we didn't get to from last week from Brandy Bauer. She asks, I'm super new to all of this. Welcome. I have moderate central canal stenosis in C6 and 7, disc extrusion as well, with left foramen stenosis causing pinched nerve. I have significant neck pain, left shoulder impingement. Any advice?
Yeah, so that's a very common type of patient that we treat using these technologies. So just to let you know, I've got more severe disease than that personally. And about 3 or 4 years ago, mine got to the point where it was very severe, 9 out of 10 pain in this area, until we got it treated. And so realize that that's a very common set of issues that we treat. What we'll generally do is those are usually platelet-based procedures. We'll go in and tighten down some of the ligaments to reduce some of the degenerative movement that's happening. We'll directly treat the nerve area with the irritated nerve. And then also it's possible that we may need to treat the shoulder itself, because there may be independent issues that have since developed in the shoulder. But very, very common issues that we treat, and usually a high success rate procedure.
Thank you for your question, Brandy. And if you've got questions and you're watching, whether it's about yourself, your body, a friend or family member or spouse who you may know, you may be living with, who's suffering from something and wants to learn, is there some other way than just more drugs, more time, and eventually surgery? Is there something I can do, even if it's early on, to reduce your risk of these progressive conditions getting worse? These arthritic conditions that involve joints, outside of them being a specific and recent trauma, are often a result of ongoing micro traumas, repetitive stresses, due to your posture, whether it's posture sleeping, posture working, posture driving, posture reading, the posture carrying your children, whatever it may be. Those structures, movements, especially the repetitive ones, are often the things that lead to the wear and tear on our joints, which means our bones, ligaments, muscles, tendons, all of those things that work so beautifully together when we take care of them. Make sure they're aligned, make sure we're moving. And in today's very sedentary, especially now work at home environment, we often lack that motion, lack that movement, lack what we've called before imbibition in the spine, the motion and movement that keeps the discs healthy and keeps things nourished and moving and fluid and so on. So if you've got questions about any of those, we're here with Dr. Centeno, discussing what you can do to reduce your risk of those injuries, and if you have them, how to help yourself heal yourself naturally. As we wait for more questions, Doc, I'll ask, help people understand, we often refer to these things like, bone marrow aspirate can help you, or PRP can help you. But I think sometimes people don't make the connection that those things are actually their body. That it's not a product, that it's not something invented in a laboratory, that it's not a drug or a entity outside of, it's a description for something your body creates for your own body. And I think it's just a massive distinction. I think most people tend to put it in a category like, well, I could try a steroid injection, I could try a stem cell injection, a PRP injection, and yet you're talking about completely different things. One is a drug that has negative side effects that accelerates degeneration and arthritis. The other is your body, the ultimate in personalized medicine. It is your specific stem cells or your specific blood perfectly designed to heal your body. You want to elaborate on that a little bit? People understand we're not talking about a thing as much as we're talking about your own body's reproducing its own cells to do its own self-healing.
Yeah, our focus has always been on primarily autologous therapies. So autologous is a fancy medical word that means your own stuff used to treat your body. So that would be taking your own blood, highly concentrating the healing platelets from that blood, producing platelet-rich plasma to inject in certain areas. Or taking the stem cells from your bone marrow aspirate, concentrating those and putting those in certain areas. So, and when you do that kind of work, you begin to realize that how you place that stuff and getting it to the specific right spots is incredibly important to make those procedures work. And that's one of the real differences between what we do at Centeno-Schultz and what others do. Because we need to be able to concentrate stuff, let's say, from your blood, taken from the normal place you would take blood if you're going to your doctor's office for a blood test, and be able to put it, for instance, into those specific places in the neck. We were just talking about that. So that would be placing it specifically around those specific nerves using X-ray guidance, or to place it right here in the shoulder if there's a rotator cuff tear under ultrasound guidance and making sure that you put it right into that rotator cuff tear. And all of those things are not easy to do. They take a long time to learn how to do. In fact, it's one of the reasons why, if you were, as an example, if a orthopedic surgeon came from one of the best sports surgery practices on earth, where they treat this NFL guy and that NFL guy, and said, Dr. Centeno, I'd like a job at your clinic, I'd turn him away. Why would I turn him away? He does not have the X-ray guidance skills and ultrasound guidance skills to do what we do. If another doctor came in who injected spine, he was really good at injected spine, but he didn't ever have any experience in injecting wrists and shoulders and elbows and knees and ankles. Again, we wouldn't be able to hire him at Centeno-Schultz. All of our doctors that work at Centeno-Schultz have gone through at least a 1 to 2 year fellowship program where they're getting specifically trained by us. We have a fellowship program at Centeno-Schultz. Some of those doctors go off and start their own practices in other places. Some of those doctors stay on to work for us. but it just shows you how much training goes into doing this work. Because again, you may have a good friend that's a doctor. He's a great guy. He's very skilled at what he does. He may even do orthopedics. But if he shows up to my clinic wanting a job, he's not going to get one because he doesn't have the training necessary to do this type of medicine.
It's so critical to understand. I'll break it down into 3 points that people need to really understand what I'll call the Centeno-Schultz Regenx difference. And it really starts with philosophy. The same thing is very true within, the spectrum of chiropractors. They have the same title, but they, in many cases, have a different approach or different philosophy. From those that are very specifically focused on the temporary relief of pain exclusively, if that's your goal, then drugs and surgery sometimes accomplish temporary pain relief. There's very few people that live on medications and go, I'm better. They're managing their pain. They don't have complete resolution of their pain. And the same thing is true with surgery. In many cases, not all, but in many cases, they go, okay, it got so bad, I had the surgery. Research shows that having the surgery doesn't not mean you're going to be significantly better afterwards. My understanding is the research shows that you're roughly about the same, which of course begs the question, why would you do it? Besides wanting to keep money circulating in the healthcare system. So it's philosophy first. If you understand the difference between let's get you out of pain temporarily and let's get your body functioning properly and correcting the cause of the physiological mechanism for the injury or for the pain, those are 2 completely different things. It's exactly what Dr. Centeno is saying. You may be a great surgeon, but that doesn't mean you understand how to think about getting the body to heal itself first. That's the first thing, is your philosophy. The second thing is you've got to know bone marrow aspirate, you've got to know PRP and which concentrations. It's not just pull it out, put it in. There's a whole, chemistry science thing that goes into making sure it's the right concentration level. It's an extremely specific scientific process with long time of what you'd call, experiments, learning, watching, seeing what works better than others, and with the registry, documenting that improvement over time. Again, most doctors don't do any of that. And then, of course, the third one is making sure once you've got the right philosophy and the right mixture, you're getting it into the right place. And that, of course, is very specific. It's the difference between sending you a letter in your town, hoping it gets to you sometime. I don't know, somebody will get it to you somewhere. It's the general area, isn't it? And somebody using your exact address. Right at the right place at the right time to make sure the message gets where exactly it needs to be. So those are 3 massive differentiators between lots of good people doing their best and the Centeno-Schultz Regenx difference, and those are the reasons why. Let's head back to some questions as they're coming in. We've got a previously submitted question from Sherry Levin. She asks, I've had spinal stenosis in my lower back for 2 years. The only treatment I've been offered is surgery. Is there any other way to treat this? So, same issue for so many people. What are your thoughts, Doc?
Yeah, so stenosis in the low back is really interesting. And it's an interesting story about the way things evolve at our clinic. So 5 years ago, if you had asked me that question, I would have said stenosis, can't treat it. You need the surgery to open that area up. And just so that people understand what stenosis means, the main central canal, that's the hole in the vertebrae as they stack together where the spinal cord and then mostly in the low back, the nerve roots go through. That area can become impinged upon through a variety of mechanisms. The disc can bulge into it, the facet joints can push. But the most common type of stenosis is there's a ligament in the back called the yellow ligament, and the Latin word for yellow ligament is ligamentum flavum. And that ligament can become much, much bigger than it normally is. It can push into the spinal canal. And so that ligament, when you bend forward, is pulled out of the spinal canal and it kind of opens it up. So a lot of people with stenosis will feel so much better if they sit down or if they bend forward on a shopping cart. Their legs will work better, their back pain will go away or will go way down. But for people with stenosis, when you stand up, that ligament pushes into the spinal canal. And then that causes all sorts of symptoms from back pain to leg, etc. Now, what happened about 5 years ago in our clinic is I started to say, you know what? We're seeing this ligamentum flavum hypertrophy. And we see lots of other things that hypertrophy in the body. For instance, we see tendons and ligaments that hypertrophy. Hypertrophy means gets bigger. Why do they get bigger? Because they're poor quality tissue. The body can't heal it, so it just makes it bigger and bigger and bigger. It just throws more tissue at the area to try to keep that ligament intact so it doesn't tear. Now, we know that I can inject other ligaments and tendons that are too big, and they'll produce stronger tissue, and they'll get smaller. So can we do the same thing with the ligamentum flavum? Problem is, no one's ever injected a ligamentum flavum. There's no textbooks on it. There's no papers on it. There's nothing. So I spent about a year figuring out how to inject a ligamentum flavum, and we started doing this procedure called the flavoplasty using high-dose PRP, and the results are crazy. Literally getting results now that I would not have thought possible just 5 years ago. So we're taking patients who have been told they need surgery to open that area up, and about 80% of the time or so, depending on how severe it is, so it might be up to 90% of the time in patients with certain types of disease, 70% of the time in patients with the more severe disease. These patients are going from a standing tolerance of 5 minutes to 1 to 2 hours. 5 minutes standing tolerance is obviously not real functional. You can't do a lot if all you can do is stand for 5 minutes. But if you've got a standing tolerance of 1 to 2 hours, you can do an awful lot with your life. And so that's generally what happens with these folks. So it's a great story about the evolution of a procedure at our clinic. Here, there's the problem. We know the solution isn't great. We know that those surgeries aren't working all that well. They're super invasive. Can we think about the problem in a different way? And can we design a treatment that's non-surgical for these patients? And that's what we've done with lots of different things at Centeno-Schultz. And this is a good example of one of those.
That's a great approach. And this is what happens when you're, you have the independence to be able to learn and research and use common sense and understand how do you use image guidance, how do you use your experience, and how do you have the freedom to be able to move things forward. Again, we keep saying it over and over again, in the traditional medical model, now worse than ever before, because of the corporate influence, because of all the risk, because of how fast information travels, many doctors, you're seeing this more and more, especially with the pandemic going on, are gagged, meaning they are not allowed to speak out. They're not allowed to share opinions that are not aligned with the corporate entity that basically supports everything. And those opinions are not always based on science, and they're not always based on what's most effective for people. They are often based on politics, and they are often based on profit. It's unfortunate. That's the reality. Do your research. If you're even anywhere skeptical or concerned of that truth, that's the reality we're living in. So being able to work with a doctor who has the freedom and independence, let alone innovative mind. This is, again, Dr. Centeno invented the field and continues to be on the cutting edge to figure out, to think about what makes the most amount of sense under these circumstances. What we know doesn't make sense under these circumstances is exactly your question, Shari, which is, let's wait until it gets so bad that we need an invasive surgery that doesn't have proof that that experience on a regular basis actually leads to greater outcomes. We know that doesn't make sense. It makes dollars, but it doesn't make sense. Let's keep moving on with questions. Doc, thank you for your feedback on that. Let's go to Kaylee. Kaylee asks, can you touch on how you make sure the injections make it into the correct spot? Let's go over that one more time, please.
Yeah, Kaylee. So we've really had to reinvent or invent an entire field to do that. So as an example, let's say we're talking about getting, and I'm just going to, I don't know what your problem is, but let's say we're talking about getting an injection into a torn ACL ligament. So when we started doing that in 2011, again, no information out there, no textbook, no study had ever been done injecting an ACL ligament. So we spent about a year using ultrasound and fluoroscopy, so that's sound waves and X-ray guidance, in order to see which was better in injecting the ACL ligament. We decided that because of the way the ACL ligament is in there, we'd have to use X-ray guidance. And then took about another 2 years once we figured out how to do it, how to perfect it. And then right around 2013, 2014, we started to say, okay, we figured this out. We know enough now. We can start to teach others how to do this procedure. So ultrasound imaging and X-ray guidance are the two main tools that we use. And ultrasound imaging works better if you've got something that's more superficial, like a rotator cuff, for instance, that you can bounce sound waves in and out of, and you can see really incredible detail these days. Or X-ray guidance tends to work better for deeper structures or structures that are encased in bone, because sound waves really can't get in and out very readily. So we actually follow the needle into the structure. And there are at least 120 different procedures that you would have to learn to work at Centeno-Schultz on using either ultrasound or fluoroscopy to get from point A to point B and make sure those cells are going into the right spot. So in the neck, that might be into a facet joint. In the knee, like I said, the ACL. In the CMC that we talked about initially, into these ligaments here and these ligaments here, both the capsular palmar ligaments and the radial ligaments, as well as inside the joint and around the median nerve. So those are ultrasound guided procedures, whereas the neck injection I talked about was an X-ray, or is an X-ray guided procedure.
And it used to be said that seeing is believing. In our case, we will say that seeing is knowing. And that's what we want to make sure, is that we know where the right stuff is going in the right place. So, Kaylee, thank you for your question. Let's head on over to our friend Tom. Hey, Tom, regular viewer. Lots of questions. Here we go. Hi, guys. Hey, Tom. Tom's got 2 questions. Dr. Centeno mentioned last week that Regenexx bone marrow concentrate injections after processing contain the highest amounts of stem cells available. Has this been independently proven? That's question number 1. Question number 2, why do you concentrate BMC over a week in the Regenexx Caymans? And actually, there's a question number 3, which is, have you tried to concentrate BMC over longer periods for greater stem cell yields?
Okay, so 3 questions there. The first question is, Tom, have we independently tested all that stuff? We've tested multiple different, well, actually, let's back up a little bit. So most doctors, in fact, 99.9% of doctors that would use a bone marrow stem cell procedure, take that bone marrow aspirate, that's the stuff that you take out, and put it in a simple bedside centrifuge kit system. So what is that? That's something that you buy. It sits on a desk. It's about the size of your average computer printer. And you take the stuff, you put it in a little plastic kit. You put that plastic kit in that machine that looks like, again, a computer printer. You press the on button. You come back at some, 20 minutes later, whatever, and you take the kit out. You take the stuff out of there. You put it in a syringe and you inject it. Now, the problem with all of that is it's a one-size-fits-all, because everyone's bone marrow is going to be a little different. And so, yeah, that's not hard to beat. And we've checked our results against actual lab tests of some of those systems. that we were easily able to get a hold of, as well as our results versus what those companies report they can do as far as concentration. So our concentration above what those guys can do is generally at least 5 all the way up to 15 times more concentrated. So that's that first question. On the second question, we're really talking about growing cells to bigger numbers in Grand Cayman. So on the first procedure I talked about, we're just taking the stem cell fraction, isolating it, concentrating it, and putting it right back in. For the second and third questions, we're talking about taking the bone marrow concentrate, taking the stem cells out of there, growing those to bigger numbers in a lab, and then injecting those. Now, as far as doing culture expansion, and that's what that's called, the only place that can be done for us is down in Grand Cayman because it's not legal to do here in the United States at this point. The United States considers that a prescription drug. So that's got to go through FDA trials. We have one of our patents in that area that's going through an FDA trial right now, but that's going to be years before it makes it out of that maze. Then, as far as growing it for more time, the problem is that regrettably, there's a risk reward in growing this stuff in culture. So as an example, for most people, you get somewhere between, let's say, 12 and maximum 18, 19 days, and you'll get good cells and many more cells. If I kept them in culture, I would get more cells, but eventually they're going to peter out and their quality is going to go down. And if I continue to push that, the quality is going to go way, way, way down and possibly even produce abnormal cells. So we get a window where we can get more cells that are still nice and healthy. And if we push it too much beyond that window, we're going to get cells that really are just non-functional and don't do much. So that's why there's a specific window there.
There you go. Thank you very much for that. Hopefully that answers your great questions, Tom. Always appreciate you watching. Will probably be our last one for today, depending on how long. We're running out of time, but Kaylee follows up by saying, I'm considering treatment for myself for AAI-CCI, but the topic you just spoke about triggered a question about my husband. He's been diagnosed with tarsal tunnel, ankle pain, and is looking at surgery, a common theme I'm hearing. Have you had success with your treatments for tarsal tunnel?
You know, we have. Tarsal tunnel is very similar to carpal tunnel, but in the foot. And so tarsal tunnel is the tibial nerve that comes on the inside of the foot. And just like here, it can get trapped under a ligament. There's also a ligament in that area as well. The surgery for tarsal tunnel, just like here, is to cut that ligament. And the problem with cutting that ligament is there are no spare parts. It's there for a reason. It provides stability. So you cut the ligament, you get instability no matter how carefully you cut the ligament. So yes, we treat a lot of patients with tarsal tunnel syndrome. Many times, a lot of issues in their back that need to be treated as well, in addition to what's called nerve hydrodissection of the nerve. So that's under ultrasound guidance. We will carefully place platelet growth factors around the nerve and break up some of the scar tissue there. So yes, we treat tarsal tunnel syndrome in the foot, just like we treat carpal tunnel syndrome in the wrist.
Great question, Kaylee, and so important, and I'm so glad you brought it up. You know, that the duct tape analogy and metaphor, I mean, everybody knows if you've got a nice piece of strong duct tape, the last thing you want to do is split it and ruin the integrity somewhere else down the line. It's solid, it's strong, it's original parts, and when you start weakening your original parts, you are creating a downward spiral thereafter. So yes, these principles apply to different body parts, hands, feet, ankles, etc. Kaylee, you're welcome. Thank you for your question. Let's sneak one more in here. Kim is asking the question. Let's see, I can't get this in here. Where did this go? Tom, you say thank you. Kim Wood is asking, has the harvesting procedure changed over the years? Do you still take 6+ samples?
We do. If anything, Kim, the harvesting procedure has gotten better through the years. So if I compare our harvesting procedure currently to what it was, let's say, in 2011, as an example, because remember, we've been doing this since 2005. It's advanced since then. We go to even more sites, and we take smaller amounts than we used to. Now, prior, we went to a lot of sites and took a small amount. Now we go to even more sites and take even smaller amounts, and we've seen stem cell yields go up on the bone marrow aspiration since then. So, as an example, before, on total nucleated cells, meaning the total number of cells we get, it was pretty rare to see a patient that was hitting 1 billion. But now I would say probably a third to 40% of our patients hit 1 billion or more total nucleated cells. So we have made some improvements. And again, what we found is, in comparing different techniques, we found that the new way was better than the old way. And again, we're constantly doing that continuous look at this stuff. As an example, I talked to the science team this morning about the concept of what happens if you go back to the same area a second time. Does that reduce the number of cells? And we looked at the data and it seemed to maybe show that. Now we're going to look at the data again and break it out to male, female, and females that were older versus females who are younger, et cetera. And we're going to do some additional analysis on all of that, trying to see if that happens, how much does it go down? And if all of that's true, and again, this is going to be 100 hours of work by the time it all gets done, just to get to the point of saying, well, if we do a second one, we probably need to use a different technique or not. That's all we're trying to figure out. Now, that's 100 hours of work with multiple PhDs in order to get to that answer. We'll publish it when we get that answer, so it will help the whole field. But that's what we do. That's what we do all day, every day. And that's also happened with the bone marrow aspiration technique.
There you go. That's our show for today. Doug, thank you for thanking us. You appreciate learning from us. We appreciate sharing with you. Kaylee, thank you for your questions. You're welcome. Thank you. Tom, we appreciate you watching. Appreciate you asking all these questions. Listen, that's why we do what we do. There's a lot of people that are sick and suffering and don't know where to turn. And, without the truly pharmaceutical, medical device, financial support that the traditional medical system has, most people discover these options, these ways in which to heal yourself that don't have the patented drug, blockbuster benefits, but are actually the most conservative ways for you to help your body heal itself. That's why we do this. But my point in saying that is that most people learn about us through friends like you. If you watch, if you learn, if you find benefit, if you go, this makes sense, why don't more people know about this, maybe even your doctor for that matter, then we simply ask that you share it. Just let other people know that this is a place they can come, ask their questions, learn a different perspective and opinion that for most of us, especially even doctors who understand how the body works, I've heard it said, a smartest consumer is our best customer. The people that understand how these things works are the ones that are fastest to go, well, of course that's the way it works. I know how the body heals itself. We're designed to do that. We just need to be doing more of it. We just got to stop being blinded by the science and all the momentum that says quick relief is just a pill or potion or ask your doctor away. It's just not the reality of the world today. Dr. Centeno, some closing comments, and then we'll sign off for the day.
We started talking about CMC arthritis, but we've really come full circle to talk about next, to talk about tarsal tunnel syndrome, lots of different things. I think what Jason said is 100% accurate. We're talking about ways for you to heal your body without those surgeries. So if you've got friends that are interested in things like this, you can't go to a party or see someone for dinner without hearing about something that's wrong with them. Oh yeah, I got this going on. I'm going to see the doctor about that. Please intervene and ask them to get on this Facebook channel so they can ask their questions.
Everyone knows someone suffering from something, so invite them to join us next week. Until then, I'm your host, Dr. Jason Deitch. You've been watching You've Got the Power. On behalf of Dr. Chris Centeno and myself, we appreciate you watching. Thanks for sharing. We'll see you Friday on the Regenix Facebook page for those that are new. Mondays, we broadcast on the Centeno-Schultz Facebook page, right here where you are. Fridays, we broadcast live, 1 p.m. Pacific time, 12 Pacific time on the Regenix Facebook page. We'll see you there. Until then, stay well, be kind.